my name's Brittany Moore. Today is October 29th, 2025, and I'm recording my HEENT video for MSN 572. Let me do a computer scan. Here is the screen of my computer, and here are my ears, and here is my room scan. This is the wall behind the computer, the ceiling. This is my table. There are my supplies. The blue card is blank. It's just to use for the Snellen. And there is nothing in here. Also, there's nothing down here but a mess. Sorry. Okay, so I'm going to get started. So I'm cleaning my hands with hand sanitizer, and just to do consent, I am the mother of this child, and I will be giving consent. I still am going to ask for his name and date of birth. So I've cleaned my hands with hand sanitizer. And go ahead and get started. Hello, how are you?
Good.
That's good. My name's Brittany Moore. I'm a nurse practitioner student with United States University. How are you?
Good.
Can you tell me your first and last name and your birthday?
James Moore, January 24th, 2014.
Great. And how old are you?
11.
Wonderful. And your mom's already given consent for this video. So I give consent for it to be recorded and uploaded to YouTube as unlisted for grading purposes and for my professors to view. So I'm going to go ahead and get started. So I'm going to do a head and ear, nose, and throat assessment on you today. Okay? So the first thing that I'm assessing is I am assessing the hair. As I'm looking at the hair, I see that the hair is evenly distributed. The hair is, it's thick, but each individual strand is fine, and it is wavy in texture. As I'm looking through, I do not see any dandruff. I do not see any areas of hair loss or hair thinning. There's no baldness, there's no lice, and there's no nits, and that's a normal finding. As I'm looking at the shape of the head, I see that the head is normocephalic and atraumatic. There's no lesions, there's no hematomas, there's no cysts, and there's no rashes visible. Do you have any concerns with your head?
No.
Great. I'm going to then palpate the head, and as I'm palpating for any depressions, any hematomas, any cysts, any lesions, any rashes, any bumps, any abnormalities. And as I am palpating the head, I am not finding any of that, and that's a normal finding. Next, I'm going to do the pocket Snellen chart. This is assessing for cranial nerve 2, which is the optic nerve. Do you wear glasses or contacts?
No.
And you do not have glasses or contacts on right now?
No.
Correct. Okay, so how this works is I'm going to have you cover one eye with this blank note card, and I'm going to have you read the lowest line of print that you can see. So go ahead and cover an eye, and go ahead and read the lowest line of print.
LTFPH.
Okay, and then go ahead and read cover the other eye.
LTFPH.
All right, and then uncovered, can you read the lowest line of print?
LTFPH.
Thank you. So this is 2020 uncorrected. I should say I cannot be 6 feet away from this patient and still stay in the video. So for academic and video purposes, I am just standing as close as I need to be, but if this were a real test, I would be 6 feet away. So he has 20/20 uncorrected, 20/20 vision uncorrected bilaterally, and the optic nerve is intact. So the next thing I'm going to do is I'm going to just do a general inspection of the eyes. As I'm looking at the eyes, the eyebrows are symmetric, the hair is evenly dispersed, there's no thinning, and the hair beneath the eyebrows is free of any scaliness or dryness. As I'm looking at the eyelids are normal for ethnicity. I'm not seeing any blepharitis, there's no hordeolums or styes, there's no chalazions, there's no signs of infection, there's no blepharitis, there's no entropion or ectropion. There's also no ptosis, which is drooping, and there's also no exophthalmos, which is bulging. And to assess for the exophthalmos or bulging, I can look from a tangential view from the side. I can also look from the top. I'm just not quite tall enough to really be able to see but that is something that I could do. So I do not see any abnormalities with these eyes upon general inspection. Next, I'm going to look at the conjunctiva. I'm going to have you just look up and I'm going to pull down. You don't have to look up that hard, but all right. So the conjunctiva is pink and moist. There's no injection, so there's no redness. I don't see any pterygiums. The lacrimal system is intact. I can see that there's no obstructions in the lacrimal ducts, in the medial ducts or the lateral ducts. And his eyes are not excessively watery or excessively dry. That's a normal finding. There's no edema or any erythema around those ducts either. So that's a normal finding that tells me that that lacrimal system is intact. Next, I'm looking at the corneas. The cornea is clear, it's free of any opacities, and the sclera is white, and it is free of any icterus. And then looking at the the iris. The iris is the colored part of the eye, and I can see that the iris bilaterally is round and equal and symmetrical. And those are normal findings. So next I'm looking at the pupils, and as I'm looking at the pupils, I see that the pupils are round and equal. And now I'm going to test their reactivity to light. So I'm going to do a direct light reactivity or reaction test and then a consensual light reaction test. So I'm going to have you just go ahead and look straight off, and then I'm going to shine a light from the side into the left eye. And as I shine the light into the left eye, his pupil constricts from 5 millimeters to 3 millimeters. If I shine the light in the left eye again, I can assess the right eye, and I can see that the right eye also constricts from 5 millimeters to 3 millimeters in a consensual light reaction. Now I'm going to shine the light in the right eye, and that eye constricts from 5 millimeters to 3 millimeters. And I'm going to shine the light one more time and look at the left eye. And when I did that, I could see that the left eye also constricts from 5 millimeters to 3 millimeters in a consensual light reaction. So his pupils are equal, round, and reactive to light, and a direct reaction and a consensual reaction. And that is a normal finding. So the next thing that I'm going to do is I'm going to test some extraocular movements and look for some nystagmus. I'm testing cranial nerves 3, 4, and 6. So the ocular motor is 3. Cranial nerve 4 is the trochlear, and cranial nerve 6 is the abducens. And I'm going to do this in a kind of star pattern. So I will turn the stool and have you look at me, and we'll turn this way. And so go ahead, and I want you to just focus on the tip of the pen light and don't move your head, okay? So this is cranial nerve 3, cranial nerve 6, cranial nerve 3, and then going across, this is cranial nerve 6, this lateral movement, and then cranial nerve 3, cranial nerve 6, and cranial nerve 3. Now cranial nerve 4, the trochlear, is involved in medial downward vision. So doing that would be if I brought the pen light in and went down, that would be the trochlear. Assessing convergence, so in that test, let me go back, those extraocular movements, testing those 3 cranial nerves, 3, 4, and 6, are intact. Also, as I was testing that, especially doing these sideways movements, I didn't see any nystagmus or any involuntary eye movements, which is a normal finding. The next thing I'm going to test is convergence. This is ocular motor nerve, so cranial nerve 3. And what you do here is this is a coordinated inward turn of the eyes when focusing on something that's coming close to you. So this is the eyes turn at the same time, and they are symmetric. So I'm going to have you look up at this pen light, and I want you to focus on this as it comes closer to your face. And I can see that as I move the pen light closer to his eyes have a medial inward coordinated turn, and that's a normal finding. That also tests, as I said, cranial nerve 3. Now I'm going to test accommodation. Accommodation is the pupils accommodating for near focus or distant focus. So I'm going to have you stare at the tip of this pen light, and as he stares at the tip of this pen light, I can see that his eye is accommodating for a near focus, so his pupil is constricting. Now I want you to look at the light switch that's over my shoulder, and as he's looking at the light switch that's over my shoulder, I can see that his pupils are dilating, and that is accommodating for that distant focus. So we have the accommodation for near focus and the accommodation for distant focus, and that is a normal finding. So next I'm going to test the confrontation, which is a test for peripheral vision. The way we do this is we do one eye at a time. So I am going to have James turn the stool and face me, and I'm going to have you close your left eye and I'm going to close my right eye, and I want you to tell me when you can see my fingers wiggling. This is the static wiggle test.
I can see them. I can see them. I can see them.
Good job. Okay, now have you close your right eye and I'll close my left.
I can see them. I can see them. I can see them.
Great. And then we'll do them both eyes open. Okay?
I can see them. I can see them. I can see them.
Great. So the peripheral vision is intact at 180 degrees, which is a normal finding. So I've completed all of the tests. Now I'm going to complete the fundoscopic exam. So the fundoscopic exam uses the ophthalmoscope. So some safety tips with the ophthalmoscope. I have my diopter set to 0. If I was in clinic, I would dim the lights so that way I can see, but I can't here for the video. And also other safety, if I'm inspecting the patient's right eye, I'm going to use my right eye and my right hand. If I'm inspecting the patient's left eye, then I would use my left hand and my left eye with the ophthalmoscope. Whatever hand I'm not using, so my hand that's not on the ophthalmoscope, will be on the patient's forehead on the brow, and that will be helping to stabilize and offer some balance and make sure that we don't have a collision. I also will hold the ophthalmoscope with my forefinger, my thumb, and then I'll have my 4th and 5th digits out so that way I have a buffer. So that way when I come in close, I don't accidentally run into the patient. So I'm going to start at about 15 inches away and at about a 15-degree angle from the sight, from the line of sight. And the first thing that I'm looking for is I am looking for the red reflex as I come around. And I can see the red reflex, so I'm going to follow that in. And as I'm following that in, I am able to see the structures, the inner structures of the eye. So I'm able to see the optic disc in the cup. The cup to disc ratio is 1 to 3. The optic disc is a creamy pink yellow color, and the margins are sharp. I can see the veins and the arteries. The veins are larger and darker in color, and the arteries are smaller and lighter. And I can see that there's no cotton wool spots, no AV nicking, and no hemorrhages. And there's also the macula and the fovea, which are responsible for central vision. And that is all a normal finding. So now I am going to demonstrate on the other side, and I don't have a lot of room. This might be a little bit more difficult. So again, on the patient's left side, I'm going to use my left hand and my left eye to do this, and we'll see. So I'm going to have to just maybe verbalize some of this. So I am coming in, and I can see the red light, or excuse me, the red reflex, and as I'm following the red reflex in, I can see the same structures that I saw on the other side. I did forget to mention that I can see the cornea and the lens, and they're free of opacities, and I can see the cup and the disc. The optic disc has sharp margins. The cup to disc ratio is 1 to 3. I can see the arteries and the veins. The veins are darker and larger, and the arteries are smaller and lighter. There's no AV nicking, no cotton wool spots, and there is no hemorrhaging. I can see the macula and the fovea, and that is responsible for central vision, and that is a normal finding. So I had the same the same results bilaterally. So next I'm going to move on to the nose, and I am going to, first I'm going to inspect the nose. So as I'm looking at the nose, I see that there is, the nose is midline, there's no deformities, no irregularities, no hematomas, there's no obvious breaks, there's no rashes, no scarring, and there's no signs of any infection or any allergies. There's no erythema or edema. And so next I'm going to palpate the nose. So I'm going to palpate for any pain or discomfort.
No.
Great. And as I'm palpating, I am not feeling any deformities. I'm feeling that the septum is midline, there's no deviations, and there's no deformities, and that's all normal findings. The next thing I'm going to do is I'm going to palpate for the frontal sinuses and the maxillary sinuses. And so I'm going to palpate here in the frontal sinus. Do you have any pain?
No.
Okay. And then the maxillary sinus is right here. And do you have any pain?
No.
Okay. That's not really working. There we go. And there's no pain associated with any of the sinus palpation. Now I am going to use my scope, my otoscope, to inspect the nose. Make sure the light is on. So I'm going to do this bilaterally. So I'm going to inspect. Let me see. I'm just going to have you kind of look up. And as I'm inspecting the nose, I am seeing that it is pink and moist. It's not pale like you would see in allergic rhinitis. There is no purulent discharge, and I see the turbinates, and they are not enlarged, and they are not obstructing. They're not edematous, so there's no edema, there's no erythema, and there's no nasal polyps, and the septum is midline. I'm going to look on the other side, and as I look on the other side, I bilaterally have the same findings. I do not see any polyps, no obstruction. It's pink and moist. There's no edema, and there's no erythema in either nair. So the next thing that I'm going to do now that I finish that is I'm going to test for patency of each nair, and I'm going to do the test for olfactory nerve, which is cranial nerve 1. So go ahead and occlude one nostril and breathe, and then occlude the other nostril. Great. And you can breathe out of both sides? Wonderful. Okay, so I'm going to have you close your eyes, and I want you to cover one nostril and tell me what you smell.
Coffee beans.
Good job. Okay, and then I'm going to have you cover the other nostril. Yep, and tell me what you smell.
Vanilla.
Great. Okay, so cranial nerve 1, the olfactory nerve, is intact, and that is a normal finding. So now I'm going to move on to the ears. So the first thing I'm going to do with the ears is I'm going to test cranial nerve 8, the auditory nerve, by running through a series of gross hearing tests. The first hearing test that I'm going to do is the whisper test. So I'm going to have you put your finger, this is called the tragus, okay? So I want you to put your finger on the tragus, and I want you to kind of spin it around in a circular fashion. There we go. I'm going to stand 2 feet behind, and I'm going to whisper 3 words. 1-A-B.
1-A-B.
Good job. And then I want you to cover the other ear in the same way. So push in the tragus and spin. Are you ready?
Yes.
2-4-C.
2-4-C.
Good job. So that shows that he has acute hearing intact. So the whisper test assesses for just overall hearing. And now I'm going to assess the Weber test, and this tests for lateralization. If a patient comes in with a complaint of unilateral hearing loss, this test can be used to assess for conductive hearing loss or sensorineural hearing loss. So what I'm going to do is I'm going to activate this and place it on your forehead. And this is testing for lateralization. Where do you hear this? Do you hear it in both ears equally, or one ear more than the other?
Both ears.
Great. Equally?
Yes.
Great. Okay, so that is a Weber symmetric. He hears it equally in both ears, so that is an indication that he doesn't have any sort of hearing loss. The next test I'm going to do is the RIN test, or Rene test. It has many different pronunciations. I'm going to test both ears, so I'm going to put this on your mastoid. Can you hear this?
Yes.
Tell me when it stops.
It stopped.
And can you hear this?
Yes.
Great. So in the left ear, his air conduction is greater than bone conduction. And now we'll do this on the right ear. Can you hear this?
Yes.
Tell me when it stops.
It stopped.
And can you hear this?
Yes.
Great. So bilaterally, his air conduction is greater than his bone conduction. So that is showing that his cranial nerve 8, the auditory nerve, is intact. So the next thing that I'm going to do is I'm just going to inspect and palpate the ears. So as I'm inspecting the ears, I'm looking for any sores, any lesions, or any discharge. I see no sores, lesions, discharge. There's no erythema. There's no edema in this ear. And then assessing bilaterally in this ear, I see no discharge. There's no edema. There's no erythema. There's no cysts, no sores, no lesions. So the ears are equal bilaterally. So next I am going to use my otoscope, and I am going to assess the ears, and I'm going to again have some safety with my scope. I'm going to hold it in a position that will protect me if the patient moves. So that way the otoscope doesn't jam into the ear. And then because he is an older child, I'm going to move the pinna up and I'm going to move it back. Oh, I would actually like to go back. I'm going to palpate the ears. So I'm palpating, and do you have any pain?
No.
Okay, I'm palpating on the pinna, I'm palpating on the lobe, and I'm palpating the tragus. And no pain?
No.
And I'm also palpating the mastoid bone. No pain. And then again on this ear, any pain?
No.
On the pinna, the lobe, the tragus? No?
No pain.
Okay, so no edema, there's no sores, no lumps, no nodules, no concerns. Okay, so I have an appropriate sized speculum for my otoscope, and I am going to look in. So I'm starting with the patient's right ear. I'm going to hold and pull the pinna up and back, kind of up, back, and out, away. That's going to help to straighten out that ear canal. And I am going to look inside here. And as I'm initially looking inside the ear, I do not see any erythema. There's no edema. I do not see any cerumen buildup. I do not see any drainage or any infection. I'm looking at the tympanic membrane, and the tympanic membrane is a pearly gray. There is no perforation and no bulging. And I'm also seeing the cone of light, and the cone of light is at 5 o'clock as I'm on the right side, and I am seeing the handle of the malleus and the umbo, and that is all normal findings. Your ears look good. I'm going to move over to the other side, and I'm going to look in the left, and as I'm looking in the left, I'm looking for the same findings. So I'm seeing no drainage in this outer ear or this external ear canal. I'm not seeing any cerumen buildup. I am not seeing any erythema, edema, or drainage. The ears are pink bilaterally, and the tympanic membrane is pearly gray bilaterally. There's no perforations, and there's no bulging of the tympanic membrane. And I am seeing the cone of light here at 7 o'clock, and I see the handle of the malleus and the umbo, and I do not see any abnormalities or any problems with the ears. And so that is done with that. So the next thing that I'm going to do is I'm going to start on my assessment of the mouth. So the first thing that I'm looking at with the assessment of the mouth is I'm looking at your lips. The lips are symmetrical. The skin on the lips is free of any ulcerations or lesions. They're not cracked, they're not scaly, and they're not excessively dry. And then I would like to look inside the mouth. So cleaning my hands and putting on some gloves, I'm going to first look in the buccal mucosa. So as I'm looking in the buccal mucosa, I'm going to have you open your mouth, and I'm going to grab my pen light just in case I need to see a little bit better. Yeah, that will help a lot. So the buccal mucosa is pink, it's moist, it's free of any lesions, there's no ulcerations, there's no cankers, I don't see any sores at all, and there's also no white patches, which is all normal findings. Now as I'm looking at the, I'm going to look at the salivary duct. So the first one I'm looking at is the parotid duct, which is up near the second molar, up in front of the second molar. and that is patent. There's no stone obstructing. There's no purulent discharge. There's no blood, and there's no edema and no erythema. And then looking under the tongue, go ahead and lift up your tongue at the submandibular duct or the Wharton duct. Again, there's no purulent discharge. There's no stone obstructing. There's no pus. There's no signs of infection. There's no edema and no erythema, and that's a normal finding. Okay, next I'm going to just have you open your mouth again, and I'm going to inspect the teeth. As I'm looking at the teeth, there's no broken teeth. There are a few missing teeth, but those are age appropriate, and I can see where the teeth are coming in. And these teeth do have orthodontia on them, so these are his original teeth. There's no abscesses in the gums, and there is no, I don't see any plaque buildup, and I do not see any dental caries on these teeth either, which is a normal finding. Next, I'm going to look at the gingiva, which is the gums, and as I'm looking at the gingiva, I do not see any abscesses. There's no hypertrophy of the gingiva. I do not see any gingivitis or signs of infection, and there's no ulcerations, no lesions. There's no abnormalities with the gingiva. It is pink, it's moist, it looks very healthy. It's not friable, so it's not at risk of bleeding easily, and that's a normal finding. The next thing I'm looking at is the tongue. So go ahead, and I can see the tongue from right here. The tongue on that dorsal surface has, it's rough. I can tell by looking at it. It's covered in papillae, and they appear to be about 1 millimeter high. He has good movement of his tongue, so good deviation and good strength. So to test the strength, this is testing cranial nerve 12, the hypoglossal. Go ahead and push your tongue into your cheek. Good job. And then push your tongue into your other cheek. Good job. All right. And that tests that hypoglossal. The next test that I'm going to do is I need to test cranial nerve 9, the glossopharyngeal, and cranial nerve 10, which is the vagus. And then I will test the spinal accessory, which is cranial nerve 11, in a moment. So first I'm going to finish up with the oral inspection. So go ahead and open your mouth, and then I want you to stick out your tongue, and I want you to say "ah." Great. So I am looking at the soft palate and the uvula. As he said "ah," I watched the soft palate rise symmetrically, and the uvula is midline. The uvula and the soft palate are both pink and moist. They are not full. There's no erythema. There's no exudate, and there is no edema and no signs of infection there. And then his cranial nerve 9 and 10 are intact. Another way that you can test cranial nerve 10 is by eliciting a gag reflex, which I will not do, but for purposes of this video, I will explain it. So cranial nerve 9, go ahead and swallow also. Great. And as he swallowed, that's another way to test the cranial nerves. So cranial nerve 9, the glossopharyngeal is intact, and cranial nerve 10, the vagus, is intact. Okay, last section that I'm going to inspect in your mouth is I need to look at your tonsils, and I need to look at your posterior pharynx, which is the back of your throat. So go ahead and stick that tongue out for me. And say "ah." All right, so I can see his tonsils, and I can see the pillars. The tonsils are +1. They're free of any exudate, and they're free of any edema, and they're free of any erythema, along with the tonsils, the pillars. The pillars and the posterior pharynx are pink and appropriate. There is no erythema. There's no sign of infection. There's no exudate, and the posterior pharynx is patent. And so that finishes the oral inspection. And so the next thing that I'm going to do is I'm going to do some lateral rotation or some neck movements with you, some range of motion. Do you have any neck pain right now?
No.
Great. So I'm going to have you I want you to do some neck rotation, lateral rotation. So just turn your head so your shoulder and your chin are aligned, and then turn the other way. Great, and then I'm going to have you just turn against a little bit of resistance. Good job, and turn against a little resistance. Good job. And as he's doing that, I'm testing for that spinal accessory nerve and also for the sternocleidomastoid muscle. I can see that activating, and that shows that cranial nerve 11, that spinal accessory nerve, is intact. I also am going to have you do a shoulder shrug, so go ahead and shoulder shrug, and that also is for the trapezius muscle, and then also for the cranial nerve 11, that spinal accessory nerve. The other test for range of motion that I'm going to have you do is I want you to put your chin to your chest in flexion, and then I want you to put your chin all the way up to the sky in hyperextension. Great job. And then go ahead and put your head back midline, and then I want you to put your ear to your shoulder, and then your other ear to your shoulder. So his range of motion is intact. Okay, so next I'm going to palpate for the lymph nodes, and I'm going to turn the chair this way. And so I'm going to start with the pre-auricular nodes, and then I'm going to do the post-auricular nodes, and the occipital nodes, and then the post-cervical nodes, and posterior cervical nodes, and then the anterior cervical nodes, and then the submandibular nodes, and then the submental nodes, and then the supraclavicular, which is a little harder because it's hard to get underneath of this sweater, but the supraclavicular. So the nodes should be kind of a rubbery consistency. They should be movable and non-tender, and they should be small, the size of a pea or smaller, and some of them are not even detectable. I'm also going to palpate the side of the trachea. The trachea is midline, and I'm also going to start assessing for the thyroid. So now I would like to have you swallow. Good job. Okay, and then as I'm looking directly at the thyroid, I am not seeing any bulge. I'm not seeing any goiter. I'm not seeing any masses or any nodules on the thyroid. I'm also looking at a tangential view, and I'm not seeing any goiters. I cannot do a tangential view from this direction. I guess I can, just doesn't feel like it's very accurate, but I would do it from both sides. And I've had him swallow, and so now I am going to do a palpation from behind him. And so I'm going to identify the structures. So the first structure that I'm identifying is the thyroid cartilage, and then moving down is the cricoid cartilage, and then this is the thyroid that I'm able to palpate, but I was not able to see. And this is the trachea. And so I can feel the thyroid isthmus, and let me see, where are we at? There we go. Okay, and I'm going to have you go ahead and swallow. And go ahead and swallow for me one more time. Okay, and I don't feel any masses, there's no nodules, there's no abnormalities, and I am feeling that thyroid isthmus, and it feels midline, and I do not find anything concerning. Let me think if I've missed anything. Let me run through. So we did your eyes, we inspected your eyes, we did a confrontation test, we did the lateral gaze, we tested your eyes and their perla, there's no nystagmus, we did your nose, you smelled, you did the Weber-Rin and the whisper test for the auditory nerve, which is number 8, we did the glossopharyngeal, the hypoglossal, and the vagus, and the spinal accessory. I think I've completed my assessment. I don't believe I've finished. There's anything else. So thank you very much. And thank you for your time, James.